Good evening, ladies and gentlemen. And I am very sorry the slight delay in the start due to my inexpert technical abilities. My name is Jonathan Barker. I am the Professor of Medical Dermatology at St. John's Institute of Dermatology and one of the consultants in the Severe Psoriasis Service, the Centre of Excellence that we have here at St. John's and Guy's Hospital. And it's great pleasure for me to introduce this evening. It's the final day of Psoriasis Awareness Week, which was kicked off by the World Psoriasis Day last Thursday. And there's been a great week of information events. And traditionally, we at St. John's hold patient and public involvement evenings. But because it coincides with Psoriasis Awareness Week, we are incredibly pleased that we are doing it in association with the Psoriasis Association. And we've honestly been slightly overwhelmed by the number of people who want to listen to me and other members of St. John's and indeed Helen. And looking at the counter right now, there's 98 people in, so that's just amazing. We'll keep things to time, but hopefully provide you with an enjoyable and highly informative hour and a half. So next slide, please, Ali. I'll just briefly walk you through the program. After my introduction, I'm very pleased that Helen McAteer, the Chief Executive of the Psoriasis Association, is going to talk to us about challenges of living with psoriasis during the pandemic. After that, two of my colleague consultants in the psoriasis service, Professor Catherine Smith and Dr. Satveer Mahil, are going to tell you about psoriasis and COVID-19, insights from the PsoProtect and PsoProtectMe registries. I think we need to give these two individuals great credit because from a standing start, they set up the world-leading psoriasis COVID registries. And already it's reported some important information that you're going to hear about that we hope will guide practice in the troubling months ahead. After Catherine and Satveer have finished, we're going to go to a Q&A session in which you have the opportunity to ask me and my colleagues, including our nurse consultant, Lucy Moorhead, and Helen. And that's going to be chaired by Karina Jackson, nurse consultant here at St. John's, who's also a trustee of the Psoriasis Association. And then we will close promptly at 7 o'clock to allow you to get home in time for the by midnight, so that you won't be out and about when the government tells you you're no longer allowed to be out and about. And on the final housekeeping slides, please note that you've all been muted and videos of you won't be visible. This is to stop feedback noises and to keep bandwidth to a maximum. Please do not film, record or take photographs of the presentations. There should be a Q&A icon on your screens. And I'm told if you can't see it, if you wave around with your mouse, it should come up. But please use that to submit questions after each talk and for the Q&A session at the end. Helen's going to take a couple of questions as we go along, but then we'll have all the rest of the questions at the end. It might be if we have too many questions, we'll only have to answer select ones, and we'll try and group them together under various topics. Please don't forget to provide feedback, and also please do not forget to continue and consider supporting the Psoriasis Association, and the two web links are there. And so without further ado, Helen, I'm going to hand over to you, if I may, the first speaker about living with psoriasis during the pandemic. Thanks, Helen.
Many thanks, Jonathan, and thank you again for letting the Psoriasis Association join the St John's Derm Academy tonight. It's really great to be here. So the challenges of living with psoriasis in the pandemic. At the start, are we moving on? Yeah, at the start of 2020, the Psoriasis Association, like many people and organisations, was busy planning activities. And like many people and organisations, we've had to postpone, cancel, pause, rethink and replan our activities. As many of you will have experienced, sometimes there hasn't been much notice and it has been necessary to respond to the need at the time. Other times we've had longer to plan and make necessary adjustments. The disruption has been felt throughout all areas of the charity's work, but particularly fundraising, where all large events have been cancelled, along with most smaller events that would bring people together. The other two areas disrupted the most have been our research programme, where access to laboratories has been restricted, along with the need to redeploy professionals elsewhere in research centres or clinical settings. And our own information production, in which the workload increased dramatically as people desperately sought information relevant to them and psoriasis. But what were the challenges people with psoriasis faced? Well, as news of the spread of the virus reached Europe, the messages were around hand washing. Many people contacted us via our helplines and social media channels, concerned by the flaring of the psoriasis on their hands and how to mitigate any adverse effects from using soap as opposed to their usual soap substitutes when regularly hand washing, and how to overcome that sting of the hand gel that we must all now use. Of course, we were in the early stages of the UK experience of the pandemic, but it soon became apparent that people with skin conditions such as psoriasis that affected their hands must still wash their hands with soap first, then a soap substitute or emollient, followed by a moisturiser, should that be necessary. It was hard, and many people were very anxious by this virus we knew very little about. Questions such as, can I catch coronavirus through psoriasis on my hands, were commonly asked at this time, with the focus still very much on hand washing as a prevention. Then, as NHS staff were redeployed to other areas, we began to see appointments, particularly in secondary care, so the hospital dermatology departments being cancelled, postponed, or carried out via the telephone or video call. There was an abrupt change or stop to therapy for some people, or people were unable to commence new therapies. This was often distressing as the appointments cancelled included those for patients already in a phototherapy regime, those for people about to start new treatments or to be seen by a dermatologist for the first time, along with people whose psoriasis was flaring, or those stable but on long-term therapy. As is so often the case, services differed dramatically around the country. In some areas, phototherapy services remained open throughout. Once made COVID secure, it provided therapy for people who might otherwise have needed to commence immunosuppressants. However, in most areas, the phototherapy services closed overnight, leaving patients confused, distressed, and unable to access the treatments that they needed. Then came lockdown, when we were told to stay home, protect the NHS, save lives, and along with lockdown came shielding. At an already anxious time, this was cause for additional anxiety amongst people on immunosuppressant therapy for psoriasis, such as methotrexate, cyclosporine, or the biologics. People were contacting us again for some clarity around what all the advice meant for them personally. There was a lot of confusion regarding shielding, who should shield, and what it meant, particularly for those classed as key workers or for people's family with whom they live. There was much worry amongst patients as to the best course of action regarding continuing their tablet or injection treatments for psoriasis. The necessity to individually reassess, revisit, and reevaluate the risk-benefit ratio between some treatments that were successfully treating psoriasis and a perceived increased risk of COVID complications for individuals taking these treatments remains a constant thought process for many. We worked with the excellent team at St John's to sift through all the advice and guidance being issued by the government and relevant medical professional organisations. And we worked with NICE and other organisations in the development of their guidance to give psoriasis-specific advice in relation to COVID. We soon established a dedicated COVID-19 hub on our website that was updated daily and was, and still is, home to many resources responding to the need at the time. For example, shielding, coping during this challenging time, face coverings, eating well, coming out of isolation, and what to expect and how to prepare for remote consultations. Whilst going into lockdown was an anxious and often frustrating time for people with psoriasis, particularly in accessing treatments and therapies, many reported to us that for once they actually had the time required to use topical treatments more successfully, particularly scalp psoriasis treatments. Whilst many found this time stressful, for some there was a reduction in stress as they no longer had their daily commute, instead having to work from home. The sunshine and generally good weather for many during lockdown 1 perhaps had a positive impact on people's mood and coping. The Psoriasis Association has been in contact with many people since the beginning of the pandemic, and I'd just like to take this opportunity to share a few with you now, which further highlights the challenges people have faced. Lucy explained that since the start of the pandemic, my psoriasis has worsened due to daily anxiety and tension. I have psoriasis on my scalp, face, torso and back, and I'm currently using topical treatment options after having previously used light therapy and systemic drugs, which caused unpleasant side effects. I would describe my psoriasis over this period as relentless. I'm on furlough, so I'm at home all day, applying, washing off, reapplying topical treatments. The salicylic acid that I put on my scalp makes my hair fall out in clumps, and the psoriasis on my body has been inflamed and sore. I'm also trialling natural options, including oat baths, which really help soothe my skin, and apple cider vinegar, which eases the redness. Everyday life is a distraction from my psoriasis, but with so many aspects of everyday life on hold, it is having a bigger impact on me than it usually would, particularly my mental health. I'm exercising regularly and trying to eat healthily to try to manage the physical and psychological symptoms associated with my psoriasis. The sunshine helps too, but I live in a flat with no outside space, so it has been difficult getting outside as I'm reluctant to visit public spaces in case social distancing isn't followed. I'm looking forward to a day when coronavirus is no longer a threat and psoriasis is just a small part of who I am, rather than a huge part of every day. Then Jessica. Jessica had to stop working on the front line for the NHS as she was classed as vulnerable. She explains that my psoriasis started to make an appearance once again. I also started to experience joint pain again, but my referral to rheumatology has been delayed because of the pandemic. Lockdown has been testing, seeing my skin slowly flare back up. With the extra time, I became a bit obsessive with skincare routines, but it has given me the time to take care of my psoriasis and try to love the skin that I am in. I've started going out with my legs uncovered. However, some days I still don't feel confident enough. But this is something I would have never done before during a flare. Now the world is trying to go back to some kind of normal, and I return to work, which has been equally as challenging, knowing my vulnerable title does not suddenly disappear. And finally, Emma. Emma explains that I was incredibly concerned for my health at the start of lockdown, not only mentally, but also physically. In February 2020, I had started immunosuppressant treatment as I'd recently been diagnosed with psoriatic arthritis. I was starting to get into a good routine with exercise, healthy eating, and attending all hospital and doctor's appointments. So once lockdown had been confirmed, I feared the worst. I didn't know if I could still get my fortnightly blood tests. I didn't know how easy it would be to access my medication. And on top of that, I was aware that the medication I was now taking is an immunosuppressant, which put me at a higher risk of catching COVID-19. Despite a few tough weeks with my mental health declining rapidly and my skin flaring very quickly, a result of stress, poor diet, and lack of exercise, I managed to bounce back. I changed my way of thinking, started to look after my body by doing any exercise I could from home and keeping an eye on my mental well-being. Not only this, but I have been extremely fortunate with the continued support I've received from medical professionals, especially my rheumatology team. They have kept me in contact through monthly calls and raised any concerns immediately with my GP. The other day, they managed to arrange an appointment with physio, and I am now starting treatment in a few weeks via video appointments. Although my joints seem to be increasing in pain and inflammation, my skin has really started to clear, so I have hope. It's not been easy, but I feel very fortunate and I'm grateful to so many people for the support I have received. So as mentioned previously, people were anxiously seeking as much relevant information to them at the time. Our website visits increased 70% in March. Our COVID information accounted for 30% of all of our page views. We had a video question and answer session with Professor Griffiths answering the most frequently asked questions or topics raised on our helpline or social media channels. These included, does taking an immunosuppressant medication for psoriasis or psoriatic arthritis make you more likely to catch COVID-19? And the rest of those questions are there on the screen. The final question, is anything being done to help better understand the interactions between COVID-19 and psoriasis? Professor Smith and Dr. Mahil will be covering in much greater detail after this presentation. Increasingly, the cancelled or postponed appointments were being fulfilled, usually via telephone or online. This method of receiving healthcare had not been experienced by many patients, and so we worked with people who had had appointments via these means and healthcare professionals who had provided appointments via these means in order to produce a really useful resource in what to expect and how to prepare for consultations that weren't face-to-face. We sought further feedback from people who had experienced their consultations via digital means in order to help shape future care. And our work in this area is ongoing with the NHS Improvement Programme. The challenges of living with psoriasis during the pandemic will continue in part once this period of time becomes history. Most people with psoriasis are treated in primary care. Primary care appointments are largely being carried out as a telephone call scheduled between 8 AM and 1 PM or 1 PM and 6:30 PM. Whilst this model was satisfactory in the short-term response to pandemic working, it's not acceptable longer term or even now. People with psoriasis have lives, families, jobs and commitments. They shouldn't be made to sit around waiting for telephone calls with a vague time frame. How can people plan for a consultation when they don't know if it will take place when they're standing at the school gate, in the middle of a Zoom presentation, or whilst nosy flatmates or family are around? Yet people are still expected to be open and honest about how their psoriasis is affecting them, to describe body sites involved, and to upload pictures. Secondary care or hospital virtual appointments are often at a more specific time than those in primary care, so people can plan accordingly. However, there has been a tendency that these have focused more on the physical skin involvement and with one member of the dermatology team, as opposed to the face-to-face clinic appointments in which more of the impact of psoriasis can be addressed, along with seeing a number of members of the dermatology team, such as the nurses, doctors, and psychologists. Then came the lifting of lockdown restrictions, and with it, a rise in people's anxiety again. Often people had felt safe and secure in their bubbles at home and were concerned what would happen. Again, we worked with Professor Chris Bundy on resources to help. However, along with the new "Stay alert, control the virus, save lives" slogan, came mandatory face masks and their added complication for people with psoriasis that affects the face and/or ears. People began seeking advice from us as to how to manage delicate facial psoriasis and avoid exacerbating it. Now they needed to wear a mask. Often, people would use a mild steroid for their facial psoriasis, but would the mask now mean that this was classed as under occlusion and so covered up, which could potentially intensify the steroid? So the challenges that people with psoriasis have faced and continue to face whilst we live in this COVID world is the controls we are required to adhere to, regular hand washing with soap and wearing a face covering, can all make psoriasis worse. Whilst the treatments for more moderate to severe psoriasis work by suppressing the immune system. We must maintain social distancing, yet for some psoriasis-related appointments, face-to-face is essential. And so there are lots of psoriasis-specific questions to COVID-19 that need answering. Therefore, it was imperative that the Psoriasis Association supported both PsoProtect and PsoProtectMe, and we have been delighted to have been a founding partner organisation to these two incredibly important pieces of ongoing research, so that we can continue to give people whose lives are affected by psoriasis the most up-to-date information, advice and support. Thank you.
Helen, Jonathan, thank you ever so much for that. I have to say that I don't know what others thought, but first of all, you've increased the audience from my start. You're now at 115, and it's so helpful from a professional's point of view to hear what it's really like. We've had a couple of questions, quick questions for you before we move on. Are you anticipating advice for patients to remain unchanged in lockdown 2 compared with lockdown 1? Or do you think advice for patients is likely to remain the same as it was before?
I think obviously we know a bit more than we did back in February, March. Time. I know that Professor Smith and Dr. Mahil and yourself, can comment further really as to, the knowledge that we now have for people, especially on the systemic or biologic medications. We've heard obviously today that the shielding will be resumed again, and the support that, will be on offer to people, just hopefully for a shorter amount of time that we'll be in lockdown compared to earlier in the year, but from what we've seen at the moment, the advice is still as it was.
Okay, thanks very much. One other quick question. Somebody's written in to say that psychological support in troubled times is really vital, and is there anything more that the Psoriasis Association is planning to do around that, either with relation to COVID or indeed beyond it?
Yes, certainly, and I think we've all experienced the downside of the pandemic on our mental health. We offer various forms of peer-to-peer support at the Psoriasis Association, mostly online, but through different mechanisms. So we have online forums on our own, hosted on our own website, or a closed Facebook group. So others wouldn't necessarily be able to see what you were talking about. We have our telephone and WhatsApp helplines as well at the charity, and it is really important to speak to others who may be experiencing similar things to yourselves. as I say, we have the COVID hub on our website. There are some fantastic resources on there with regards to coping, and certainly for people who may now need to shield again. And we will continue to update those, but certainly there's a number of different resources available for people to not feel lonely, which is often difficult in the winter months anyway. So.
Yeah. Well, thank you very, very much. And you're staying with us, and you'll be answering questions in the panel Q&A a bit later. But just before you go, again, from the professionals, a great big thank you for the incredible work that the Psoriasis Association does in producing information and supporting people. We appreciate it very much. So thank you, Helen.
Thank you very much.
To keep the show going, I'm now going to hand over to Professor Catherine Smith and Dr. Satveer Mahil, who are going to tell you about their amazing initiative during the COVID pandemic with PsoProtect and PsoProtectMe. So, Catherine, I think you're going first, aren't you?
Yeah. Well, thank you very much, Jonathan. And I would say this effort has definitely a collective effort across many organisations and countries, and actually fundamentally also patients who've entered data into our registries, as well as dermatologists across the world. So it's really been a collective effort. And I'm just going to do a very brief introduction, and then Satveer is going to show the results of the registries so far, and also our direction of travel, what we're planning in the future. So just to start off with, and to give a little bit of context, Satveer, so COVID-19 is a new disease. It's also called coronavirus disease, and it's caused by this virus here that you can see on the right, so-called SARS-2 CoV-2 virus, which stands for severe acute respiratory syndrome, which indicates, of course, that the main problem with this virus, once you get the infection, relates to pulmonary disease, pneumonia, and then acute respiratory distress in those who get a severe form. And the way that the virus gets into the target cells is via those red spiky things on the surface of that molecule that you can see of the virus that you can see there, the so-called coronavirus spike protein. And it's against that many of the vaccines being developed are focused on that. And this virus is incredibly infectious. It spreads very rapidly from person to person. And this is why the 2-meter distancing rule is so incredibly important. The main mechanism for transmission is through saliva, through coughing, and through the nose when an infected person coughs or sneezes. And next slide. The impact of this pandemic has been profound. And this is latest data from the WHO here, downloaded on the 1st of November. And on the y-axis, on the left, is the number of cases. And on the right, Satveer, I don't know whether you can illustrate, on the right is the number of deaths. That's right. And then you can see then the blue line represents the number of deaths over time. And that now cumulatively has reached over 1.2 million people. And the cumulative number of cases is now 45 million cases. And you can see here this bar chart with the different colours representing the different areas in the world. And in particular, the fact that we've now got this big uptick in Europe with really dominant infection in Europe, and it remains a problem. Next slide. So what are the impact of coronavirus infection? Many people have no symptoms, and this has obviously been a real challenge in terms of managing the pandemic. But most people, and this was very reassuring data that came out quite early on, really have a mild to moderate disease and fully recover. And the symptoms include a cough, shortness of breath, temperature, myalgia, and then typically also loss of taste or smell. But a minority of patients do have a severe illness, and one of the indicators of a severe illness is the need to be admitted to hospital. And those patients who are admitted to hospital with pneumonia and then ongoing into this so-called acute respiratory distress with profound hypoxia requiring ventilation, but also a whole number of other so-called extrapulmonary problems, so outside the lung, involving many organs, including the kidneys, kidney failure, liver problems, problems with clotting, which is now managed much better, and a whole sort of array, and including a number of skin problems, skin rashes, and so-called chilblains. So in those people with very severe disease, this is the group that is so important to understand who those people are. And the evidence coming through now indicates that these, as listed on this group, are those who are older, men, those in Black, Asian and minority ethnic groups, and those with underlying health conditions, including in particular obesity and diabetes. Next slide. So in the context of this sort of whole pandemic, and actually Helen, it's interesting going through all of that timing and remembering it, because you sort of forget it, but the whole cycle of information and things that we need to be doing. Next slide. And then this whole thing about shielding. And we were involved in trying to configure advice around shielding, working with lots of the other specialist societies, so not only within dermatology, rheumatology, neurology, and so on. And thinking about in this group of people who are taking drugs that affect the immune system. And this was being done in a complete vacuum of information. We really had no idea actually whether these drugs were in fact a risk for patients. We had no information. And so it was challenging. But thinking about psoriasis particularly, and what would it mean to our patients in the clinic, there are really three things that were coming into mind when we're thinking about this. First of all, psoriasis is a condition that involves the dysregulation of the immune system, and many of the pathways involved in psoriasis overlap with those involved in COVID-19 infection. So that was one concern. The second was this issue of drugs and how they might impact on people taking them for their psoriasis. And we also knew that from previous work that people with psoriasis, particularly those with more severe disease, had a number of the conditions that were coming out in the general population as being risk factors for more severe disease, including obesity, diabetes, and so on. So there were a number of reasons why we needed to know more about how this would impact on psoriasis. And these were questions that were coming to us in the clinic, and it was difficult because we had no information. So are people with psoriasis at increased or lower risk of getting COVID-19? How do people, when they get COVID-19, if they have psoriasis, how does that impact on the course of their disease? Are there any particular risk factors for severe COVID-19? How do the drugs affect the outcomes in COVID-19? And also, what was the impact of this pandemic on people with psoriasis, knowing again that people with psoriasis, not everybody, but many carry a burden of anxiety, low mood, and already to some degree social isolation. So those were the really key questions that we were trying to address and thinking how we could. And it was really that drove this initiative that happened really incredibly quickly, and it was an extraordinary experience in that one of the silver linings to the whole thing is the way that the community came together very rapidly with the Psoriasis Association to develop and kickstart this initiative. So I'm going to leave it there, Satveer, if you want to take over.
Okay, Thanks, Catherine. So as Catherine said, there were a lot of questions that suddenly came up at once, and lots of answers were missing. So we started on the journey to try and address some of these key issues, and we set up PsoProtect, which is a global registry for healthcare professionals, doctors, nurses, looking after people with psoriasis, to report outcomes of COVID-19 in individuals with psoriasis. And we launched this early in the pandemic on the 27th of March. And this effort wasn't alone. So it's unique to psoriasis in that it's a global registry for COVID and psoriasis, but we very much aligned it with other similar efforts in other immune diseases, such as inflammatory bowel disease and such as in inflammatory joint conditions that were also being set up all at a similar time. It's very simple, actually, how to submit information. So we ask clinicians to go to our website, which is psoprotect.org, and for any of their patients who have COVID and psoriasis to fill in a very simple form, which collects only de-identified, so no personally identifiable information is collected in this form, and but clinicians were very rapidly able to provide a lot of key information on how COVID was presenting in people with psoriasis, and how actually people were recovering from the condition, and of course all of the relevant information on, say, you know, what their weight was, what their age was, and also what drugs they were on, so drugs that affect the immune system. All of that was recorded in this form, which took about 10 minutes for each clinician to complete for every patient. Alongside this, we set up a sister registry called PsoProtectMe. Now, this is for individuals with psoriasis to self-report their experiences of the pandemic. And we asked people to fill in this survey, and we're still asking people to fill in this survey, whether or not you have COVID, because we're interested in understanding, for people with psoriasis as a whole, as a community, how is the pandemic affecting you? So we launched this soon after PsoProtect on the 4th of May, and we very much align the questions with PsoProtect, so they're very much complementary, the two efforts. And thanks to the Psoriasis Association and Helen and her team, we were able to get really great engagement from the community with this effort. And I'm going to talk a bit about the data that we've collected. Because we were asking people to submit their own information, we were able to ask unique questions that actually the clinicians looking after patients wouldn't necessarily be able to answer. So we're asking about behaviours in terms of risk mitigating behaviours. So were people shielding? So even if you were advised to, were you doing it? Or perhaps you weren't advised to shield and you were doing it anyway. So these were some of the bits of information we were able to collect. And again, a website was set up, which is psoprotectme.org, and you can enter your information by just going to the website and clicking self-report here. And that opens up a very simple survey form, which takes about 10 minutes to complete. And this is now available in 7 different languages, thanks to a great team effort from a lot of colleagues in helping to translate our survey. So it's very much a global and inclusive effort. So aim 1 for the project was to understand the course of COVID-19 in people with psoriasis. And I'm going to tell you today about our first collection of patients, which is 374 patients with COVID-19 and psoriasis. And these were all patients who were reported by their healthcare professionals to PsoProtect. So this is a clinician reported registry. And this, we cut the data on the 1st of July, and we've just released this data has just been published, and the link to the scientific research paper is at the bottom of the screen. So the 374 patients came from 25 different countries. You can see 36% came from the UK, 21% Italy, and 15% Spain, and another 22 countries in that. 61% of those patients reported to the registry, so these are patients with COVID and psoriasis, were male. The median age was 50, and the vast majority were of white ethnicity. And we saw that most patients who were reported to PsoProtect had other health conditions. So we know that obesity is very strongly linked with psoriasis, and sure enough, a third of the patients who were reported had obesity. Just over a quarter had high blood pressure, and psoriatic arthritis, which is also closely associated with psoriasis, and in particular severe psoriasis, we had just over a quarter of patients with that, and diabetes was also prominent. Most of the patients who were reported to PsoProtect were receiving a drug, either a tablet or an injection drug that affects the immune system. And you can see here that 71% of the patients who were reported to PsoProtect were on a biologic injection medication, which is given for moderate to severe psoriasis. 18% were on traditional therapies, and by this we mean agents such as drugs such as methotrexate or cyclosporin. 10% were on no treatment. And we'll talk a bit more about the significance of that at the end when we talk about the limitations of the study. So what we did see when we looked at the course of COVID is that the symptoms that people with psoriasis reported to PsoProtect were having looked very similar to what the general population was suffering when they presented with the infection. So 68% of people had a fever, 48% had fatigue, and then dry continuous cough. These were the top 3 symptoms. So very much in keeping with the pattern of how the infection presents in the general population. And this here is looking at the outcome. So once you've got the infection, what is the end result? And what's really reassuring, and what was, what really came out very strongly here, is that 93%, so the vast majority of patients with COVID and psoriasis completely recovered from their COVID infection. 5% had what clinicians had termed a chronic complication, which is a medical condition that was that sort of continued after their COVID infection, and we were asking clinicians to report after at least 2 weeks. So one limitation is actually we don't have such long-term data on this, but the clinicians at the time when they put in the data felt that 5% had a chronic complication. 9 patients out of the total 374 died, and the median age was 65, with a very wide range there going up to 89. And one thing that we saw with all 9 who unfortunately passed away from COVID, all had at least one underlying health condition. Now, Catherine mentioned that when you look for markers of severe infection, so people who are particularly badly affected by COVID, you can, as a marker of that, you can look at hospitalization. So you can see whether someone needed hospital care or hospital admission for their COVID, and that is a marker for particularly severe infection. So we used that as our main outcome when we were looking at the data, and we found that 21% of patients were hospitalized for their COVID infection. 12 patients of the 77 who were hospitalized needed ventilation, which would be done in an intensive care unit. And the median length of stay was around 11 days. And again, when we looked at data from the general population, well, it's very difficult to compare this data that's collected in a registry like this to data from the general population, which is collected in a different way. The figures are roughly the same there in terms of the length of stay in hospital. So moving on to our second aim, so we looked at how COVID presents and, you know, the proportion of the patients in PsoProtect who needed hospital care. Well, what factors are associated with hospitalization for COVID? So we wanted to know what things may be associated with a severe outcome in people with psoriasis. And we found that hospitalization was more common among those patients with established risk factors for severe COVID. And by this, we're referring back to that slide that Catherine showed, where from the general population, these are the risk factors that were emerging and that emerged pretty quickly and early on in the pandemic. So we see the same risk factors coming up for psoriasis. So we found that more males were hospitalized compared to females. More patients who were older in age were hospitalized, so 60% of over 70s were hospitalized compared to 10% of patients below the age of 50. Non-white ethnicity was associated with hospitalization, as we're seeing in the general population. And other health conditions are associated with severe COVID infection. So 76% of those reported to PsoProtect who needed hospital care had high blood pressure, heart disease, diabetes, liver disease, or chronic lung disease, for example, COPD, compared with 34% of non-hospitalized patients. And the final thing that we observed was hospitalization for those reported to PsoProtect seemed less common amongst those receiving biologics compared to other treatment groups. So you can look here, this is the figure that I showed before, and of those in PsoProtect, you can see the majority were receiving biologics, but of these patients in green here, 17% of those needed hospital admission. And that's lower than the percentage of the patients receiving traditional therapies. So it's small numbers, and we only had 67 people reported to PsoProtect who are on a traditional therapy, but of those 34% needed hospital admission. And of those on no treatment, which again is very few, 29% of those needed hospital admission. But this data is, it's important to interpret it in the context of the limitations of this study and all other registry-based studies. So we're not alone in scrutinizing, you know, how the data are collected and how to interpret this, which is really important. So one thing that we were really keen to sort of emphasize is that these are not causal observations. So it may be that there are other unmeasured factors that are associated with, say, taking a biologic drug that is contributing to this lower proportion of hospitalization that we're seeing in patients who are receiving biologics. So in other words, it's not the drug per se that's causing that association, it's other factors that are associated with taking a drug. And in particular, this relates back to the risk mitigating behaviors that I'll come to in a moment. So in particular, shielding behavior. So one thought is it could be that people taking biologics are shielding a lot more carefully and a lot more stringently than perhaps people taking other types of medications. It's really important to emphasize that this is small numbers of patients overall. So there are 374 patients in this registry when we did the analysis, which is small numbers compared to the number of patients affected by psoriasis. So it's 125 million patients who are affected by psoriasis globally. So this is a sample. It's dominated by patients taking drugs that affect the immune system, particularly biologics, and this could be a feature of dermatologists. So doctors based in hospitals who were prescribing these medications were the doctors and the nurses who were submitting data to the registry. So it's likely that they're seeing patients who are mostly on these medications. So that's one factor to bear in mind. And also, we also felt that doctors and nurses may well be more likely to report patients who've had a severe outcome, because it's likely that their patients have been in contact with them, they've been more involved with their care, and they know more about, they've heard back about the severely affected patients, compared to, say, the patients who've had that mild infection, got over it, and got back on with with their everyday life. And importantly, as I've mentioned, we can't compare data collected in the registry through PsoProtect with the general population. But this is very much a beginning, and we can draw some interesting conclusions from it. So one thing that's really interesting that came out was that the majority of patients reported to PsoProtect who were taking drugs that affect the immune system, and you can see that the majority of our patients were. They fully recovered from COVID. So that's, as a first conclusion, very reassuring. Older age, male sex and non-white ethnicity were associated with a greater risk of hospitalization for COVID in people with psoriasis. So as Catherine mentioned, when we began this journey, one big question was, do people with psoriasis, when they get the infection, behave like people in the general population? Because it's an immune condition, there's lots of overlap with COVID itself. Will people with psoriasis behave differently when they get the infection? It looks like the risk factors are the same. And similarly, health conditions that are associated, such as chronic lung disease, high blood pressure, heart disease, and liver disease, were more prevalent. They're more common in people who were hospitalized. And we are, as I mentioned, that data cut was in July, and we've continued to collect data, and the registry is still open, particularly now, as we're seeing cases going up again. So it's important that the data continues. So I just wanted to finish by saying thank you to everybody who has completed the survey. It's been really humbling for us, the team here, just to see so many people engaging with it so well, and we're incredibly grateful to everybody who's filled it in, because it's been really informative, and it's been a great way for us to understand more about how the pandemic has really affected people beyond just the patients that we have in our clinic. So thank you. And if you've not filled in the survey, please do, because it's very much open, and we're very much keen to get more data. So that's the website, and it's, as we said, it's in 7 different languages, which are listed there. And we have a current data page that we update on a weekly basis. We update the counter, and it's a flavour of the data that we have there that's accessible to all. So please do have a look at the current data page. So this is a thank you to everybody who's been involved. Catherine and myself and Jonathan and Chris Griffiths in Manchester have led it in the executive committee, but it's been really championed so well by our international colleagues from abroad who are listed here in the International Scientific Advisory Board, and all of our study team who have really worked above and beyond to sort of help us deliver the data in good time. And we're really grateful to the Psoriasis Association for partnering with us and helping to spread the word. And these are the other patient organisations who've partnered with us, and all of the professional organisations too. Thank you very much. That's just a little graphic that we've produced to try and summarise just the findings from the initial PsoProtect paper.
Satveer, Catherine, thanks ever so much for that great work and presentation. I'm just going to hand over now to Karina for the Q&A, but just while we're doing that, I think there's an important question come through, Satveer, probably for you. Is someone's a little bit reasonably, I think, slightly confused about filling in PsoProtectMe. Is this something that you're asking people to do once, or are you asking them to do it regularly as the situation might change? Just quickly answer that while Karina takes over.
Yeah, absolutely. So obviously when we launched this, the idea was to fill it once, but everyone who's filled it in has a code, has a survey code. So once you've filled it in, you will have a survey code. Please keep that, because situations do change, and we're really keen for you to update your survey as it changes. If you do need to change your survey and update us, you go back to the original self-report here, and there's a little box for you to put in your survey code. So one of the questions is, are you filling this in for the first time? So then you put no, put in your survey code and update the survey. We have our contact details on the website as well, so very, very welcome to contact us. But absolutely, so if when you filled in the survey, say you hadn't had COVID, and then situation changes, please let us know and re-report.
Thank you.
Thank you so much, Catherine and Satveer. We have had lots of questions coming through, a range of topics. What we were going to do is just take a very quick comfort break, visit the bathroom, get a glass of water, and then we will be right back to work through some of those questions with our panel. So we'll be back very soon. Thank you for your patience. Okay, welcome back, everybody. Helen, have we got you with us? Or are you still making a cup of tea? There she is. So I've got some assistance here with the questions that have been coming in. And obviously, with the new lockdown, there's lots of concern again about shielding and this question of shielding. And literally today, I think there's been a new announcement from government with guidance on that on the website. Now, I know, Lucy, you had a lot to do with supporting our patients when we were giving advice earlier this year in lockdown 1. Yeah. We've had a few questions about drugs specifically. One question was, I had to shield previously on Cosentyx, so does today's news mean I'll need to shield again?
So looking at the guidance, it looks like that anybody who was asked to shield in the first lockdown is being asked to shield this lockdown. Again, you can be on Cosentyx monotherapy and not need to shield, but if you are on Cosentyx and have other relevant comorbidities, then you will have been asked to shield. And I think if you've got any questions or queries, really to contact your prescriber to clarify the situation. Mm-hmm.
And by monotherapy, you mean just
Cosentyx, just Cosentyx and otherwise fit and well.
Yeah. And there was another question actually about methotrexate. So the same, a patient is on methotrexate and it has not been told to shield at any point. Should that person have shielded?
Well, so if they are on methotrexate and, as I said, otherwise fit and well, so not on any other medication and doesn't have any other medical problems, then they don't need to shield. But if there is any concern or they're worried or they have started a new medication or anything has changed, then again to contact their prescriber and just to talk through their own individual situation.
Thank you. Thank you. So, I mean, obviously we're all holding out for the vaccine that hopefully is going to have an impact in society and enable us to hopefully live more normal lives again in the next year. The question here is that this person has had COVID earlier this year whilst on methotrexate, and continues to take DMARDs. Is a vaccine going to be A, appropriate, and B, allowed if this person is on methotrexate when the vaccines become available? Would one of our medical panel like to answer that question?
Well, I'll start, but I think first thing is that there are a lot of different vaccines being developed all at the same time, and there are different types of vaccines. So as people will know who are taking drugs that affect the immune system, the advice is not to have live vaccines, that you should not have live vaccines. None of the COVID-19 vaccines at the moment are live. And in fact, one of the reasons for that is that there's been a recognition that the people most likely to need and benefit from vaccines are people in this group who are taking immune suppressants. So that is sort of being considered. But there are two things when thinking about taking vaccines in the context of drugs that affect the immune system. One is in the case, considering the case of a live vaccine, then if you have a live vaccine, then you're at risk of getting that condition. Well, for COVID, that doesn't seem to be likely to be a problem with the vaccine that are being developed now. However, the other thing is, how does the immune, if you've got a suppressed immune system through the drugs, how effective would be the vaccine? In other words, would your body be able to mount a sufficient immune response? I mean, we already know actually that, you know, people taking drugs that affect the immune response still do get good responses to vaccines. So, you know, we advise everyone to take their flu vaccine every year and so on. But in the context of the COVID-19 vaccine, it's hard to really know the answers to that question. But it is subject to intense research, actually. And this group of individuals who are taking drugs that affect the immune system is, you know, recognised to be a really important group that need to be considered.
Mm. And another question in relation to vaccines actually is from somebody who has nail psoriasis, quite mild skin psoriasis, but not on any systemic therapies for that. So would they be allowed to enter into a vaccine trial? Are you aware of any reasons why they wouldn't be able to do that?
No, I wouldn't have thought so. No. I mean, Jonathan or Satveer, have you got anything else to say about the vaccines? Because I don't know whether I've covered everything.
No, Catherine, I think your answer is very good. I mean, I think it's an incredibly challenging situation. I think we have to watch and wait. There is going to have to be some guidance about who can and can't have a particular vaccine. And as you say, there is a whole range of vaccines. So I think we should be optimistic that there'll be at least one that you can have if you can't have another one. Sorry, Satveer, go ahead.
No, I was just going to add to that, Jonathan, and just say, well, at the heart of this work are people who are vulnerable and with comorbidities and on drugs that affect the immune system. So it's very much at the forefront. We're not directly involved in any of the vaccine work, but it is 100% at the forefront of their minds to make sure that you know, that group are included.
So we have a few questions here in relation to your research work, Catherine and Satveer. And the PsoProtect question about the data that's been coming through. Question, is there a reason why most respondents were white male, yet BAME has a higher incidence?
Yeah, definitely. So it's an interesting question. I think it comes down to, you know, what we'd call ascertainment bias. So in the people who are reporting the cases mostly are seeing mostly people who are not BAME. So, you know, the vast majority of the patients probably in their patient population are white taking these medications. But what is interesting is that was still a signal. So despite the vast majority of patients who are reported to PsoProtect being white, we still saw that there was this association between non-white ethnicity and severe outcomes, showing that in many ways that's quite reassuring that it's a true signal. So despite a minority being reported who are not white, it still came out as significant. But I think that the fact that the majority were white is more about how the cases were reported, and you know well,
it reflects the demographic of the countries where we had the most reported. So it was dominated. That data cut was from the UK, Spain, and Italy, and those, you know, so it's reflective of the, you know. We've pushed really hard as well. I mean, we've worked so hard with our global partners to try and get better representation. I mean, we've really tried hard. And in fact, with these new publications, we put another big push, and we've partnered. Helen, you might want to say how you've been working with the global organisations. I mean, and also that was one of the reasons why we had translations and so on. I mean, to try and get, you know, a more representative cohort. Helen, I don't know whether you want to say something about that.
Yeah, the PsoProtect and PsoProtectMe communications team meet weekly to discuss our communication strategy, and really have worked very hard and extensively with organisations around the world, so other patient organisations and other healthcare professional organisations, and as Satveer spoke about earlier, actually getting the translations into the 7 different languages was a really great step forward. So we will keep promoting.
Right, another question relating again to, I guess, whether we're seeing any data yet, but is there an increased risk, any increased risk for Stelara and becoming seriously ill? There has been emerging evidence about cytokine storms, which are suppressed by biologics. Jonathan?
I think you should be relatively or very reassured that there is no emerging evidence that any of the biologics that we are using to treat psoriasis has any highly significant adverse effect on COVID. And that's kind of precisely why these registries exist. We started, the starting point here is that these drugs affect the immune system and have been classified as immunosuppressants. And we've wanted to know exactly how much of an adverse effect they might have. And, you know, I think we should all be relatively reassured today, Helen, and I think, you know, your members, but we obviously, there's big caveats. We need more data. But there are many studies around the world which tend to suggest that the initial worry is not borne out in real life, and that applies to all of them, not just Stelara. So look, watch this space, but do not think that these drugs have a highly significant adverse effect. And I think one of the other things that we haven't yet mentioned on this webinar is what is the risk of not treating psoriasis or other medical conditions for that matter. You know, this is a balancing act, and we always, regardless of COVID, it's always a risk-benefit balance that the doctors, the nurses, the healthcare professionals, and people with psoriasis have got to work out together.
Are there any further questions about that?
No, only just a comment actually that Satveer mentioned that
Can't hear you, Catherine.
Oh, can't you? Can you hear me now? Yeah. Satveer mentioned that we designed PsoProtect to be aligned with other registries in other disciplines, so in rheumatology and gastroenterology, and reassuringly really that the findings in PsoProtect are very much the findings in the other registries, which gives us some confidence that what we're seeing is a real finding, that these drugs are not, you know, a major risk in the context of COVID. I mean, as Satveer says, there's lots of caveats about that, but on the whole, and also, Jonathan, it's true, isn't it, anecdotally, you know, talking to colleagues across Europe, that people aren't seeing, you know, in clinic, we aren't seeing people with major problems taking these drugs. That's the other thing. I mean, I feel much more relaxed than I did in March when we set this thing up, because we had no idea then, absolutely no idea. And I feel, you know, very reassured about it. And actually, I'd agree with Jonathan. The bigger problem now is people perhaps being worried about taking drugs and not treating their psoriasis. And I think that's, you know, that's potentially more problematic if you've got, difficult psoriasis that is having a big impact on your life.
Can I just one other point on this, and it relates to here we are thinking that things are reassured, and at the same time, as Lucy has informed us, is that the advice is about shielding again. And just to let everybody know that, of course, high-level governmental advice can only follow the data. It can't come out at exactly the same time as the data. So there's always a time lag between generating the data, like Satveer and Catherine are doing with PsoProtect and PsoProtectMe, and it being incorporated into governmental advice. So just bear that in mind. And that's why it's so critical that the sooner we have all this information, the sooner we can go to the powers that be and say, look, here is the real life evidence. And then that advice can change. People hopefully will be a lot more relaxed in the future.
Thank you. We've got a few more sort of medically focused questions. And I guess this is a fair question, given that we hear a lot about this great, cheap medicine that's now going to help people get better if they get COVID. So one of the problems with COVID-19 is the inflammation cascade, and that can be suppressed by dexamethasone. So would, therefore, dexamethasone be a useful treatment for psoriasis, which is an inflammatory problem?
That's definitely one for Catherine as the pharmacologist in the group.
Well, steroids, dexamethasone is a steroid. And so steroids were actually used in psoriasis in the old days. It's generally an intervention that we don't like using in psoriasis in the modern era, because particularly when you stop it, it can cause a flare in disease, and we've got much better targeted therapy. But having said that, if you were given dexamethasone as part of a treatment, which is exciting, the fact is that is an intervention that's been proven to be effective in COVID-19 severe illness. If you were given that as a person with psoriasis, then it's likely that actually it would have a benefit for your COVID. It's likely it may well have a benefit for your psoriasis, but it isn't a treatment that we recommend for psoriasis per se.
And like you say, Catherine, I mean, the data is on people who've got very sick already. So they've got bad COVID, they're in hospital, potentially in intensive care, and then it's given. I mean, I guess that the question relates to, should I be taking it, and how would that affect my chance of getting COVID? And that there's no recommendation there, because the data is, as Catherine said, it's on a very specific population of people who are already very sick, and yeah, so it wouldn't be recommended for people who have just, say, in the general population or got psoriasis, because we don't know about how it affects the risk of catching it and recovering initially.
I have a sort of more general question about psoriasis and comorbidities here from a mother of a teenager who has getting back pain with psoriasis, and wonders what she should be looking out for and what she might do. Could I ask one of the medical panel to answer that? Satveer, maybe?
Yeah, sure. So back pain, I mean, it could be an indicator that something's wrong with the joints. And I guess the first thing to do would be so if you were coming to say us here in our clinic, we routinely ask about joint symptoms whenever we see people in clinic, because it's part of our screen for an inflammatory condition called psoriatic arthritis, which is an inflammatory joint disease which is associated with psoriasis. And we do a questionnaire-based screen for everybody attending the clinic, which is on the basis of symptoms of joint pains. And on the basis of that, you would then do an examination and then refer on to joint specialists. So I'd say if the back pain is a prominent symptom, and it sounds like it is, then the thing to do is to tell that a healthcare professional, whether that's your dermatologist when you go and see them, or GPs who would be very well placed to do the assessment as well. And then the next port of call, should it be deemed as something that needs further investigation, is then there'd be a referral onto joint specialists. But it's something that arthritis is associated with psoriasis, and this is exactly why we've got these screens integrated in our clinic.
And just on another tangent, Helen, in terms of support for teenagers with psoriasis, I don't know whether the Psoriasis Association have had much contact during COVID from teenagers with psoriasis, but are there certain materials that teenagers and families can access?
We have a separate standalone website specifically for teenagers and young people, which is soteen.org.uk, which will have more tailored information for young people and teenagers. On there, obviously we have our WhatsApp service if anybody doesn't matter of the age would like to contact us in that way, or feels more comfortable contacting us in that way as opposed to the traditional telephone routes.
Wonderful, thank you so much. So we do continue to get questions related to COVID, and of course people are trying to often manage their psoriasis independently of being able to access the full range of services available. We have a question here about phototherapy, and of course during lockdown one, the many units shut their phototherapy services. Hopefully that isn't going to be the case again continuing on, but somebody has asked a question about accessing UV treatment at home. Do any of the panel know much about this and whether there may be opportunities for that, or maybe it's a regional thing?
Do you want me to have a go at that? This is a very challenging thing, and of course there is a sort of mantra in healthcare that treatment and healthcare should be closer to the home, so we ought to be championing phototherapy at home, but there are big challenges in delivering it. About the only place in the UK where they do it routinely is up in Scotland, in Dundee, but they've got a very sophisticated setup there, partly because of the geography and the fact that the population is so spread out. I mean, it's impossible for people to go to the centre, but there are big challenges about dosimetry, about cost, and governance of it, that in general, I think we collectively as dermatologists, until those issues are resolved, we're not usually in favour of it. Bear in mind that the machines are not cheap either.
Yeah.
Lucy, do you have a lot of patients from daycare asking about this, or is this more of a problem seen in non-metropolitan areas?
I think it's probably non-metropolitan areas and people who are struggling to access treatments. And I know that there are now private companies who will offer to hire UV treatment machines as well. And there are other smaller handheld devices as well that are available. But I think the message sort of remains the same, that you can never really guarantee the dose that you are getting. Yeah.
It's certainly an area that patients are exploring at the moment, sometimes in response because of their own phototherapy having been halted, obviously, but also as an alternative to if they needed to go on to methotrexate or other immunosuppressant treatments. So it's certainly a question that's going to keep coming about, and as you said, Jonathan, there's a great service, the PhotoNet service in Scotland, but we've just not been able to replicate particularly well in England. There was a bit of a startup in Cardiff. I'm not really sure how well that's gone though.
Okay, I'm watching the clock. I've been told that we have to finish on time this evening, otherwise we're going to all get locked into the department. And I know we haven't answered all your questions, and there are quite a few about using topical treatments and managing psoriasis in flexural areas. What we would like to do is just put all these questions together with the answers and share them with Helen and the Psoriasis Association, and then maybe Helen, there's a way that you could share those through your website or other means, maybe through the email addresses.
Yeah, absolutely.
And I'm also very mindful that we've been a bit England-centric with our advice on shielding. I can see quite a few comments have come in about Wales and Scotland having different approaches to this. So I think we just sort of need to finish by saying, clearly you need to follow your local government advice on shielding, or however it is termed locally. But if you are concerned about your medical conditions or problems, then perhaps reaching out to your healthcare practitioners, GP, or otherwise, to find out what your status is and what measures you might need to take over and above the advice that is being given about general social distancing and taking care. And I'd also like to finish by saying a big thank you to our panel who have done a sterling job this evening for all your wise words and contributions. And thank you to you, our audience, because we've had lots of lovely messages coming through thanking us for putting this on with the Psoriasis Association. And I think I can speak on behalf of all the team to say we're delighted to do so and enjoy it very much. So back to our chair, Jonathan, just for a final word.
Okay, well, thank you, Karina. There's still 89 people tuned in, which is about where I started, and then Helen got them going, and then we're back to where I started. But that's amazing at 7 o'clock at night. Look, I can only repeat what you've just said. Helen, thanks for doing this with us. Derm Academy at the St. John's Institute of Dermatology is a new initiative that Satveer runs, which is dedicated to informing and educating healthcare professionals across the whole of dermatology and allied specialties. Ali, whose name you can see on the screen, and she's in the background. She works tirelessly, but never presents herself. She only deals with technological problems that I have and then fixes them. And Alison is all there's Ali, and then there's Alison also, who's been frantically collecting the questions as they've come along, just to make sure the whole thing works. And this is all down to Derm, and there's Ruth somewhere around as well, isn't there? So thanks to all of Derm Academy, and I'm sure you'll see them around again. Psoriasis Awareness Week is very important. I have a second job as president of the International Psoriasis Council, and you know, we recognise World Psoriasis Day and the importance that the WHO has in making sure this important condition does not go unrecognised. And it's great that you as an audience have posed important questions to the panel, and some of which Professor Smith is going to answer in writing via the Psoriasis Association portal. So thank you, panel. Thanks, Karina, for hosting the Q&A so well. And again, thank you to the 86 people who are still out there paying attention. And we look forward to seeing you at our next PPI. Take care, everybody.